Thank you. Jeremy Hughes from the Alzheimer's Society, and obviously representing people at the sharp end of what you've outlined today. And I was expecting to be interested and encouraged, and I have been by what you said, but I'm also excited, and I think that's a step beyond what I was expecting to be. So I think it's great to think about what we're doing over the next 6 months. However, there's always a however, what you're unveiling today is a health review led by the health team. I think what you've talked about demands response from other government departments. And I would like some reassurance that DCLG, your opposite numbers there, DWP, maybe even the Shadow Chancellor, would be on board with where you're going to get to, because there's no good health coming up with an answer if other people don't buy in.
Thanks so much, Jeremy. And I'm really pleased to hear you mention the word excitement. I mean, that's what I want to build. I mean, genuinely, I want people to feel that and feel they have the ability to think big thoughts, perhaps beyond a parameter than they were previously thinking. You know, that is the whole purpose of this review, and why we're doing it early, so that people have the time to do that. And of course, you're absolutely right. It can't be done by the health service on its own. Joan at the beginning described the problem with that debate about health. It is exactly the right way. It gets trapped on the health service and it doesn't take that broader view of health, and I think we need to break through that. So, of course, I've been talking to Hilary Benn, to Liam Byrne, to Stephen Twigg, to all of the Shadow Cabinet colleagues who have an important stake in this agenda, and of course, the move to the Health and Wellbeing Board in a much more prominent position does take that much broader view of health into account. And I mentioned in the speech about NICE taking a broader role. And I remember very well, you know, I mentioned some of the moments that have changed my thinking. When NICE was looking at Alzheimer's drugs in the middle part of the last decade when I was a minister, I remember feeling it a nonsense, really, that they couldn't take a view of the costs on councils or individuals of whether or not those drugs should be recommended. And that, in a microcosm, really kind of explains the issue, doesn't it? You know, that the health service takes a narrow view of its own interest, but doesn't actually consider a wider societal benefit of doing things differently. So it did begin with much of my thinking about Alzheimer's. So I hope the agenda I'm outlining today means a lot to your members and they can see the benefits it might bring.
So I'd like to hear from a GP colleague, Richard, in this row here, and then I'll come back over there. Please say who you are.
Richard Vautry, a GP in Leeds and from the BMA. Good to hear sort of about a lot of what you're saying, but GPs already know that hospitals are very good at shifting work out into the community, but not shifting the resources. You talked about the incentives on hospitals to actually provide resources to provide care in the community. How exactly would that happen? Are you talking about scrapping PBR?
Changing it, possibly, but let me just take the principal point. I mean, I understand that. I would understand nerves about hospital takeover. I mean, we've obviously seen that in the health service down the years, but you know, that's in the current system, in the current world we've got. What I'm saying here is we need to tilt the entire system away from the hospital and towards the home. And that only becomes possible when you bring in social as part of the mix. Because social was out of the NHS, as I was saying, the home has kind of been out of bounds for many people in the health service. It's seen as not the health service's territory. But when it comes into play, you then can tilt that system decisively away from the hospital and start with the home. So the change I mentioned to PBR might be year of care. Again, an idea that's just there for discussion. But if we were giving an annual approach to funding for somebody with COPD in their 70s or 80s and a number of other comorbidities, obviously it then becomes essential to keep them out of hospital, because that's the way efficiency would work. And then of course it follows that more money has to be spent in the community and in primary care. So all of those details to be discussed, but you know, the principle is a system where the financial incentive doesn't work towards the hospital, but actually moves away from it.
Okay, so if we can take the microphone, is it Julia at the back and then Robert at the front to get a couple more perspectives, please?
Thank you very much, Andy. That was really inspiring. I agree with Jeremy. I'm Julia Manning from 2020 Health. I've got two questions, Richie, really patient-centred. Absolutely with you on having national entitlement and not having a postcode lottery. And in theory, NICE has already got the legal mandate over drugs, but we have an awful lot of local variability. So how are you actually going to make it happen on the ground? And secondly, we believe that until patients are at the centre, having control of their records, and we can really kick back against some of the paternalism that we have from all sectors in healthcare and social care, that we're not going to get the integration that is really possible and will make the NHS and social care sustainable. What do you think?
Both points I completely agree with. And to be honest, the whole question of patients and their fundamental rights, for me, is incredibly important. And it is my answer to those who might say, you're creating very big, unresponsive providers. This was a path we began to go down in government, but it was underdeveloped. I brought in the NHS Constitution, and that began to explore this whole area of rights. But truly out there, how many people really know about them? The right to NICE-approved treatments and technologies. It's an underdeveloped agenda, but I think in the world I want to build, it becomes something where we would invest far more attention, and actually we would give people meaningful rights, as opposed to choices that may not necessarily meet with what matters to them. We in government were saying, which provider do you want to go to? And actually, what they were looking for was something more fundamental than that. The right to, as I said, dialysis or chemo in the home would be a much more meaningful choice for somebody, and actually gives them that control. So, as part of this agenda, that strengthening of the patient is absolutely central, and that, of course, would follow that they must have all information and be fully involved in every aspect of their care.
Robert.
Robert Naylor, I'm the Chief Executive at University College Hospital here in London, rather controversially described by David Nicholson recently as part of the commanding heights. However, we've had the pleasure of meeting you on several occasions recently as part of the Shelford Group, which represents 10 of the largest and perhaps most influential hospitals in the country. And I think you know that we are also excited and supportive of the whole notion of driving towards integration. We've long argued that integration of healthcare is the future, not competition. However, there are concerns that we have, particularly those of us in London. There's a fragmentation of local authorities in London, 31 local authorities I think it is, and our concerns might be the fragmentation and the problems of postcode lottery with different councils taking different views about standards that they expect from their hospitals.
Well, thank you, Robert, and thank you for the broad welcome. But I do understand those concerns, and I think the way to answer them is to look at the best of what's happening around the country. In London, we have a similar situation. You describe the situation. It's replicated in Greater Manchester, but the 10 authorities of Greater Manchester are moving towards a community budgets model, when there is a consistent approach across the whole city region, and it would fit entirely with everything that I'm saying. One of the ways of answering your concern is that national entitlement. What is every person's entitlement to health and care? Making that absolutely clear in a way that it's not made clear at the moment. And because it isn't made clear, I think that creates the space for people to start introducing arbitrary variations or tweaking the NICE criteria, doing different things, introducing thresholds or restrictions. And I think we need to take that away, because that is creating confusion in the system. But I don't think that it's impossible, therefore, for councils to work together. In fact, I would encourage that approach, because particularly when it comes to specialist services, we need that sub-regional or regional view of services, and that is something that I think the system urgently needs to think more about. I do think we need to think about the separation of generalist medicine from specialist medicine. I think it's too often a bit of a jumble at the moment, and I think we need to think a bit more clearly about what needs to go where, but give the teaching hospitals and the specialist centres the clarity and the stability they need to provide the very best care, and in many cases the best care in the world.
Gentleman over there, then I'm going to come to Sarah, I think it is, on that side of the room, please.
Thank you. I'm David Wrigley. I'm a GP in Lancashire, and I speak for Keeper NHS Public, which seeks to bring, it's an apolitical organisation that seeks to bring about a publicly delivered NHS. So I think it's music to the British people's ears to hear you mention the NHS as a preferred provider, removing market forces from the act that we saw. So I've just wondered, will you be sending a message out today saying to the private sector your time in hoovering up NHS contracts and hoovering up profits from the NHS is limited, and how will you actually deliver a preferred provider status from 2015?
Well, thank you, David. It was my policy when I was Health Secretary, but what I'm trying to do today is articulate it within a very different system, and I think it will then make more sense to people in a different system. But I want to probably take a slightly different view from what you've just said. I'm not saying what you just said. I did say in my speech that there has been and always will be, in my view, a role for the private and voluntary sectors in the delivery of care. They do and have brought innovation to the system. Some patients will want to go with the voluntary sector or the private sector, and that should be their choice. What I am saying, though, that should be done within the context of a managed system. The move towards an any qualified open tender approach, in my judgment, starts to cause chaos, fragmentation, and it creates a moment where the critical mass of core emergency provision could be threatened by the genie out of the bottle approach that is currently being adopted. So that is the view that I'm putting forward. I believe it does fit with where the vast majority of people are. They value the NHS and what it represents, but people don't have a closed mind about other organisations that may contribute to make the NHS even better than it is. So that's the model on which I'm basing my review. But let me just say this: inherent in NHS preferred provider was always the notion that if the NHS didn't come up to scratch, then it doesn't get in perpetuity the right to carry on providing poor care. It was basically the notion was the NHS gets the first chance to change, it gets the space to change, to embrace a new way of doing things. And that was designed to facilitate the reform the NHS was going to need to go through in this period when there wasn't more money around. But if it doesn't make that change or won't make that change, it should always be the case then that people say, well, look, patients can't put up with a poor service here. Others need to come forward who will make that change. So I think I need to put those caveats in while accepting the general welcome that you gave.
So, Sarah,
there will be different ways of doing it in different places. And I think sometimes the mistake we make is that the NHS is all the same everywhere, and of course it is not.
Yeah.
And I would be open to a range of models about how this can be done. What matters to me is the public and their experience of it. Is it coordinated? Does it give them a single point of contact? If mum or dad goes into the hospital, can the known social worker go with them and carry on supporting them on the ward? Those are the things that matter. Now, as long as we can deliver those things and the public can say, actually, this is a real change, or if the public says, I want my care at home, I want to die at home, can this system deliver it? That, in the end, is what matters, not whether hospitals take over them or GPs. That, to me, doesn't matter. It's the way it could be done in a whole number of ways. Well, I apologise, because Torbay is not London, and I appreciate that. And politicians talk about Torbay probably makes people think, oh my God, well, this should come to my area. It's different. It's a settled community. It doesn't have the challenges that many other, certainly London or other parts of the country have. But it was interesting to see the policy there of an open plan office, GP at the centre, managing, triaging the at-risk older population every day. What's this person going to need today? Is district nurse, or might need a GP? Or that is the kind of different model that that we need to start to think about. Not waiting for people to come to the GP surgery and only a subset of the population ever making it, but thinking differently about keeping people out of hospital. So that does imply changes for general practice, but obviously primary care is at the forefront of this model.
I've got lots of people who want to come in, Andy. Are you happy just to run
absolutely,
a little bit longer, just to let the debate and discussion roll? So you were next.
Dr. James Mumford, the Centre for Social Justice. Thank you for your excellent speech. You talked about demand ratcheting up for the healthcare needs associated with the ageing society. Do you think, in terms of the big picture and the total expenditure from the state in the 21st century, associated with this, do you see integration as a way of coping with those costs, and as a solution to that, or do you sort of see the dependency ratio just increasing ad infinitum?
Thank you. Well, that is absolutely at the heart of my thinking. You know, the idea that there isn't going to be huge amounts of new money just to pay for new things. So how do we take this 120 billion budget and get more from it for people? And if there isn't going to be any more, well, let's get the best that we can for what we've got. So that is where I start, absolutely. But I am clear that we can get a much better service for older people, particularly if we think differently about how we do things. If we start in the home and support them in the home, providing what it takes to keep them comfortable, confident, just happy at home, then I am certain we can avoid costly expenditure on keeping people in hospitals. And you know, what I described in my speech, just to say this again, is it's not just that people fail and go into hospital and the tariff that they then pay when hospitals have somebody in hospital. It's that because the acute ward doesn't have that whole person care, doesn't have the social care, the mental care, that's why people drop like a stone often in the acute environment. And then they will need even more intensive support, possibly in a nursing or residential home. And it's not fair to them, but it's not fair either to the public, because we're wasting money having a system where that is how it works. And you know, leaving social out of the equation was kind of possibly doable just about in the 20th century, but it absolutely is not doable for me now, because if you haven't got prevention, the preventative piece of this system, in a world where you can invest in it, you will be basically having things working in entirely the wrong direction. So when I say turn it on its head, that's what I mean. You know, so I don't know what the finances will look like in 5 or 10 years' time, but I do say whatever happens, you've got to get more for people from what we've currently got, and that's what I'm coming to. But just a final thought as well, that shift in commissioning to the broader agenda, the Marmot agenda, looking at the linkages between health, housing, leisure, highways, that too is part of it. You know, if we don't change behaviour to cut rates of obesity, if we don't get people in work so they're not suffering from mental ill health and having prescriptions for antidepressants, you know, if we don't make that kind of change, then the demands of the 21st century will overwhelm us.
So I'm going to take 3 questions together now, and then we'll have a final comment from Andy. I'm going to take them in the order I've seen them. Is it Stephen over here?
Thank you, Stephen Dalton from the Mental Health Network at the NHS Confederation. You much to be applauded in what you said, Andy, and thank you very much for your frequent reference to mental health, which is much welcomed. Just wanted to check, you seem to have a lack of appetite for organisational change in the question of commissioning, but can I just check that your lack of appetite for organisational change extends to the provision of care as well?
And Roger, you were next, and then there's a gentleman at the back. If we can get a microphone over there, that'd be great.
Roger Boyle. I was National Director for Heart Disease and Stroke during 11 years of the Labour government. I couldn't stand the next lot, so I got out. And I would really like to say how much I appreciated your speech, and really admire the notion of having a national consultation on this, because we need to build up the knowledge and momentum and understanding of the general public about these critical issues, and for them to understand that if the current government remains in charge, we won't have a National Health Service beyond the next election or soon after that. And so this is mission critical for me, and why I won't actually retire, even though I get my state pension on Monday. But I spent yesterday in Somerset helping the commissioning group there sort out their plans for stroke services. And what's clear, at the end of a long discussion with the GPs locally, was that you need to take a broader approach than just the local CCG, and you actually need a regional view, if not a national view, as to how you might configure services. So this balance between what is specialised and what is not is changing as modern medicine develops. And you know, this current regime of decimated clinical networks, which Liz has pointed out very clearly publicly, we're told now it'll be clinical senates, academic health science networks, none of which have actually started work properly yet. And I just wondered how you viewed that important issue about how you take decisions across bigger geographies.
So last question at the back, please.
Finn McCall from the Independent Pharmacy Federation. And thank you it's a wonderful idea and it's the right concept. And in fact, many of our members are doing things like having citizens advice clinics and counsellor clinics within their pharmacies at the minute. And we certainly do an awful lot in public health and mental health. But actually, the how cannot be left at a local level. There are many silos that we've all worked in for many years, and these need to be broken down at a high level as well. So we implore you not just to look at the how at a local level.
Okay, Andy.
Okay, well, thank you very much for all your comments and all that you've said. I mean, Stephen, I am troubled by the separateness of mental health from the system. I remember receiving the Bradley report, the Alan Johnson commissioned when I came in as Secretary of State, and the shocking finding about the numbers of young people in the criminal justice system with mental health problems, kind of out of sight, out of mind. And I think it's drawn on some centuries-old tradition, isn't it, that the asylum is there and it's kind of away from everybody else, and no one else needs to worry about it or go there. And that is kind of carried over into the modern NHS, the idea of separate organisations, separate buildings, providing a separate service for separate people who are not quite like us. And I am troubled and don't like that. That isn't to say, though, that we just scrap all mental health trusts. So again, the question arises, things can be done differently. But it is to say, I want mental health clinicians throughout the busy acute hospital available at all wards to provide, and an A&E, to provide the support to people who need it. And as we see in parts of the NHS, but it should be much, much more developed than it currently is. And if there was a model of full integration, one organisation on provision, I wouldn't stop it, but nor would I mandate that somebody had to do it. I can understand mental health fears things in the same way that primary care fears things. Oh my goodness, it's a takeover again of the physical, the hospital, the acute hospital. And so I understand the nervousness there. But actually what I'm saying again is the 21st century is tilting us in your direction, not away from you. The kind of pressures we're all under means that to seek mental health support is going to be something that everybody might have to do at some point for either themselves or their family, or they may find themselves in a situation where they need it and we can't go on with it not being there. So everything I say, I hope you'll take it in that spirit. But I do want to end that culture of separateness between these two worlds because it really is something that its time is over. I think the mental health debate is changing in Parliament, and that's a wonderful thing. But we need to build upon that as part of this whole person care vision. Roger, thank you for everything you said. Your comments on the current lot are better than anything I could say. You're absolutely right. I mean, Liz has done a fantastic job in exposing the changes to clinical networks and the damage to clinical networks, which are beginning to deliver such huge benefits to everybody. But your question really was about the bigger geography point, and I know you've been very closely involved in the Children's Heart Review, and obviously we saw there one of the trusts involved legally challenging that review. And this takes me back to that point about the market. Now, as I say, I'm not opposed to more autonomy of organisations through foundation trust reforms. I am not opposed to other providers being involved. But what I am opposed to is that free-for-all in a system where, because every hospital's on its own and being told to think and act like an individual business that is kind of an island, you will then get that happening more and more, where if a reconfiguration comes forward, trusts fearing a loss of status that might come with a reconfiguration will challenge it and say we're not having it. So the ability of the system to make the bigger changes that I was describing in response to Robert's question, the cross-city changes or the regional changes to reflect how, as you say, Roger, medicine is changing, possibly become less and less possible when you remove the planning function of the system. Our service consumes the lowest amount of GDP of all of the Western world's healthcare systems, because we can say at national level, well, that should go there, that should go there, this is where that should go, and that ability to plan is the strength. And if we take that away, we will regret it, I think, hugely in years to come. So, yeah, it is absolutely at the heart of my thinking that we need that ability to make those bigger decisions, and as I think you were implying, separate more the specialist from the general. So I envisage the DGH growing more into its own community, growing out into the home, into the social, providing a much more whole person approach. But then the other side of that is, of course, the specialists coming more and more to the places that really know what they are doing. And let's educate the public about that. So it's much better at times to be in those centres than to be in the DGH. And perhaps as part of this, in answer to Julia's question about patient rights, we need to do a bit more of that, about the NHS saying the NHS isn't the same everywhere. In a truly life-threatening situation, there are some places where you are much better off, and politicians need to be honest about that. Finn, I take your point completely. I understand what you are saying, and some of the changes that we introduced as a government were driven by national service frameworks, where we did tell people, here's the how. So, I'm not saying that we can completely dispense with that notion. I do feel that pharmacy is the very, very front line of this system, because I mentioned in response to the question about the broader view of health, too many people getting antidepressants rather than being helped into work. Pharmacy needs to help there in saying, look, there are alternatives to medication in a whole person world where you can do more things for people. Let's really do those medicine use reviews, and let's really push the system towards that preventative model. There will always be a case for nice advising on the how, or new developments coming that have to be adopted quickly everywhere. But I do think the logic of this system works is that we don't kind of step in and say, you must do it like that, and this is the new directive. We're learning from our time in government. In the end, people didn't want that top-down approach. They didn't want that dictatorial approach where, we won't say we were dictatorial, but we were kind of as though we were trying to run everything from and obviously that isn't what's going to be the way that carries people with us. So what I'm trying to do here is get the balance right between the two. So Chris, sorry. Yeah.
I just want to ask you one final question, put you on the spot, really picking up from what you just said. Your party was in government for 13 years, you were Health Secretary for some of that time. Why wasn't more done during that 30 years to progress the agenda you've been setting out for us today?
Well, Chris, I think much of it was done. There were many reforms we brought through to bring a system that gave people more control, personal budgets in social care, care trusts, care trust plus, where we were encouraging the pooling of resources, and obviously Torbay happened when we were there. We were encouraging people to do that. Norman Warner's here today, and he and I were ministers in the department, and we never would have stood in the way of those things. What I would say, though, is that when we came in, as what I was trying to say in my speech, the problem was hospitals and people's access to the system. Just that was the big problem. People were dying because they couldn't get in the system. So that is where our thinking began, and those were the kind of lines on which the policy was set. And I think there did come a point where, without taking the whole person view, other things, we were not responding as quickly as we might to other things that were happening. And that story of care of older people built over the second half of the last decade to where we are now. So you do need to reflect. You do need to, look back and say, well, actually, did we manage to change the emphasis as quickly as we might? But I do reflect on those things. And there was a kind of possibility that when you have targets based around the speed with which people access the system, it did at times miss the kind of human side of care. And so I've reflected on all of those things, and this is what you're hearing today, the product of a lot of thought. A lot of that experience as a minister, coming through into opposition and just seeing the government's changes. And I've really tried to put it into a coherent whole on the theme of the day for people today. But of course, people have asked some really good questions, and I want to say that it's open to be built. I'm not going to. I want you to feel that you can build this with me. I'm really grateful actually for everything that people have said and the broad welcome you've given me today, and indeed to you, Chris, and the fund for hosting this. The Shadow Health team are here with me today: Diane Abbott, Liz Kendall, Jamie Reid, Andrew Gwynn, and Debbie Abrahams, who's my PPS. We want, over the next few weeks and months, to be out there talking to all of you to get this thing right, to make it feel right to you, because we are clear that at the next election, we can't have a situation where no one talks about health anymore and big changes come. The time has come to kind of put two visions of the future on the table and let people decide. but at least let people decide, knowing that they've had a chance to shape it. So that's what we're all about. You know, we're very grateful that all of you, so many of you, have made the effort to be with us on what is quite an important moment for Labour and opposition. And you know, I hope you'll stay involved as we take this forward. Thanks very much.
Thank you very much.